Good morning, everyone, and thank you for joining us today. My name is Melissa Miranda. I'm the QIN-QIO Regional Lead for the Collaborative, and I'll be moderating today's webinar. Before we get started, I just want to cover a couple of housekeeping items. This webinar will be recorded and the presentation available on our website, www.healthcarefornewengland.org. The phone lines will be on mute for the duration of the presentation, so please don't place your line on hold during the webinar. If you have a question at any point, please enter it into the chat panel to the right of your screen. I'm joined by my colleagues from each of the state's QIN-QIO teams, and we have Maria Silva Odom here who's monitoring the chat for questions. There'll be time at the end of the presentation for us to address all of the questions. And also, if you're finding that your presentation is a little cut off, just locate the plus and minus icons in the top right corner of the screen of your presentation window and adjust your view. Today's session concludes Learning Series 1 on Transitions of Care. Our goals have been simple, that the New England nursing centers will apply strategies and best practices to aid in reducing hospital readmissions by 20% or more over 5 years, now 4 years left. The intended outcomes of this virtual learning series is to save the lives and improve care by ensuring that your staff has a working knowledge of transitions, knows what to do, and is confident that they're doing the right thing. It is also important that as a community we become adept at care transitions. As you know, this learning series is a virtual library of information and education about care transitions and various topics that directly impact transitions. It's intended to be a resource for you in educating and supporting staff. So let me just quickly review what is available in the virtual library that's available to you at 24/7. We have all of the recorded webinars for Learning Series 1 as well as all of the modules themselves. Ask that you create a QAPI team and provided a guide to help you get them started. That was called the Series 1 Guide. With teams formed, you can use the information in the series to help focus on the efforts that impact care transitions. All of these materials are available on the website. So what's ahead? We actually have scheduled an in-person event, well actually 2 in-person events. This is a great opportunity to bring our nursing centers from all over New England together. We are holding the same event on 2 different dates in 2 different states. We're holding the event first on October 29th in Concord, New Hampshire, and then we'll repeat the same event in Worcester, Massachusetts on December 3rd. We're hoping that you'll be able to attend one of these events. The topics are going to be covered are value-based purchasing in skilled nursing facilities, moving your STAR rating, and rehabilitation therapy training. These events actually are replacing the November 12th event that was shared in the calendar we handed out at the start of the collaborative. We've updated the calendar within the Series 1 guide as a reference. Post these events, our next Learning Series 2, will begin. The topic is reducing the use of antipsychotic medication, and that begins on December 17th. So the objectives for today's session are to continue focusing on how QAPI supports your improvement, learn what other nursing homes are doing to implement the education and quality strategies so far, and then to introduce the next 2 modules in Series 1. The impact of clinical risk on care transitions, focusing on falls, high-risk meds, and HAIs, and how quality in your clinical outcomes will support your ability to be a transition referral source. So let's get started. I'm happy to introduce our segment called Share from the Chair. Today, Andrea Rathbone, from the administrator at DeUville Senior Care in Lowell, Mass., is joining us, and she's going to be talking about her work and what she's been using the data for in her quality initiative. Andrea has been a nursing home administrator for 14 years. She has a master's in health administration from the George Washington University, and she's been in her current position as COO and Director of Post-Acute Services at DeUville for 5.5 years. Prior to this role, Andrea served as the administrator with Genesis Healthcare for 7 years, where she was very active in their culture change initiatives. Andrea? Thank you. Thank you, everybody. Good morning. When the QIO first asked us to talk about our participation in the CMS demonstration project and to discuss how we look at data before, now, and perhaps even in the future, I have to say I was a little skeptical because as an organization, we really view that we are in process. You know, when you look at your quality journey, is there ever truly an ending? And that's why, in the beginning, we were a little hesitant. But, we did decide to come on board and hope we can share with you some of the initiatives that we looked at, where we were, where we are, and perhaps provide some recommendations for other SNPs that are out there. So thank you for the invitation. Next slide. Prior to the QAPI project, as an organization, our data was very much in a narrative format. We did use some graphs, but they were nothing fancy. We did review the usual suspects. The clinical indicators were reviewed, falls, medication errors, skin incidents, reportables, and explanations were provided for each clinical indicator. We looked somewhat in a silo at each of those indicators to say, okay, yep, we're checking that off the list. We had X number of falls, X number of medication errors, and then just waited to report the following month. Next slide. So when we started in the CMS QAPI demonstration project, our question after participating in 4 collaborative learning experiences, which were just very valuable for us as an organization, and also as professionals, we got to meet some great folks. Our big question was where to start. When you have this information, you have these tools, you have samples of the documentation that you can use, where do you start? As a team, just like everyone else out there, we have a lot of data. Our goal was to try to move from repeating our data and our incidents, so just repeating those numbers, but we wanted to move to look at trends, we wanted to look at benchmarks, we wanted to look at, most importantly, at systems. With those systems, we wanted to understand, and I think that's probably an important word, is understand how do these indicators all tie together. For example, if we have an increase in our number of medication errors, how does that correlate with other indicators such as overtime, such as turnover, such as retention? That is where we really wanted to be. But how do you become so sophisticated with all of this data and make that work? Again, my last bullet, there was so much data. We have data from what we collect and what we track. We have NGS data. We have data from ACA. We have data from Advancing Excellence, Leading Aids. We can go on and on. Next slide. Changes that we made as an organization during the QAPI project. Now, Do the Life and Wellness Community is an independent organization. So we were really developing this based on lessons and the learning collaboratives that we participated in with the CMS project. We implemented a dashboard that displayed each of our clinical indicators over a period of time. So instead of taking each indicator in a silo, as I mentioned a few minutes ago, what we did was we had on the big screen, and if you can visualize this, on the left-hand side we had our list of clinical indicators, and then across the top we had the time frame, month, with each particular month. And at that point we had the opportunity to look at trends over a couple of months, over a couple of quarters, which really gave us an opportunity on where to focus. In the beginning, if an indicator met the benchmarks that we created for ourselves, we didn't spend a lot of time analyzing the data. If there was, unless there was a trend, it was right there in front of us, then we took the time to talk about it. Next slide. So I say that we are not at any particular endpoint, but we are certainly a work in progress. And I think if we look at ourselves as an industry, we have to be a work in progress as our industry continues to evolve over time. Data is cumbersome. So how do we use it to ensure effective change and to ensure we maximize our efficiencies? The demonstration project provided us with many tools for us to trial. We communicated during these
learning collaboratives that sometimes those tools became a little overwhelming to us, but we did have the opportunity to trial and error. So we are slowly moving away from data repetition to meaningful discussion on trends. If I could give any piece of advice, it's just trial and error. It's over and over again, looking at that and saying, how does that correlate with this piece of information? Next slide, please. Where are we now? Well, we're now using the dashboard to review trends, and I might add that we've actually, within the last month, went from that initial dashboard that we created to even a little more sophisticated one. And I can certainly, if folks are interested in seeing that, you can feel free to email me, and I'm happy to share that with those on the call. We have incorporated data into everyday use. So we tried not to let it be overwhelming to our team. We're a large organization. Across our campus, we have 241 beds. So we do use data now more so than ever in staff meetings. When we're having conversations with frontline staff, we invite our frontline staff to attend any type of QA discussion. We look at the data and we give them that information. Sometimes our staff had no idea that the amount of overtime that we may have been running and how that correlated with some other clinical indicator. And they have the best ideas. I could say that over and over again. Our frontline staff, they do have the answers. So it's important for you to touch base with them. We correlate the data across all disciplines, which we as a team find very meaningful. So our quality meetings have shifted from more of a discussion on trends and improvement measures systems, and away from that, we had 15 falls, we had 12 med errors. We really are looking at our big picture. But again, I hesitate in saying that we're done because we're not. We have to always be looking at how this data works with each other. How does one rely on the other? How does laundry correlate with what nursing's doing? And we can name many, many indicators. So it's very, very important to be okay with the fact that it is trial and error. But as long as we're learning from it, it's okay. Next slide. So in conclusion, my recommendation from our experiences over the last couple of years is to be okay with trying a process and tweaking it as you go along. There's no magic answer. But by the nature of QAPI, you are allowing yourself to look at a process and to evaluate it on an ongoing basis. So that's what you have to remember. And I think in an industry where some of us tend to be pretty task-oriented, you have to remind yourself of that. By the very nature of QAPI, you have to be evaluating on an ongoing basis. Thank you.
Thank you, Andrea. If anyone has any questions for Andrea, please share it in the chat so we can address it at the end of the session. It's good information, and the sharing portion of this webinar is very important to us, so thank you. Next, I'm happy to introduce Dr. Lynn McNicoll. Dr. McNicoll is our consultant physician faculty during this collaborative, but let me just give you a little bit of her background. Dr. McNicoll completed her residency in internal medicine at Northwestern University in Chicago, and after completing a fellowship in geriatric medicine and clinical epidemiology at Yale in 2002, she joined the faculty of medicine at the Warren Alpert Medical School of Brown University. She's now the Associate Professor of Medicine and specializes in quality improvement initiatives in both the hospital and the nursing center. And she's the Director of Education for the Division of Geriatrics, overseeing most geriatric education programs for the residents and medical students at Brown. Today, Dr. McNicoll is highlighting information from the learning module entitled Improving Areas of Clinical Risk, along with experts from the University of Massachusetts Medical School. Lynn?
Thank you, Ms. Melissa, and good morning, everyone. I want to thank you all for logging in, and I'm excited to share a sneak peek of Module 8 with you all, Improving Areas of Clinical Risk. Next slide, Melissa, please. As clinicians, whether you're a nurse or a nurse practitioner or a physician, I think that we inherently are adept at assessing risk for all our patients all the time. I think we intuitively know when someone is at risk for a complication which may result in a readmission. I think our blood pressure goes up a little bit, our antennas become honed in, and it's because we have a lot of experience. We assess a patient as to whether, a resident as to whether they are likely to have a complication or readmission. We look at their inherent or intrinsic risk factors, or whether there's something within the nursing home or the hospital or the experiences that they had in their transition that might put them at risk for complications. And then we ask ourselves, how closely do we need to monitor them? Do we need extra labs, vital signs, fasting blood sugars, etc.? How much attention do we need to pay to medications? Do we accept as is? Do we make changes, both of which have their risks associated with it? Should we touch base with the primary care physician or other providers that have managed this patient prior to us? And sometimes that's easy and sometimes not, but it takes additional attention and care. And does the care plan make sense to us? And it often doesn't, and we need to get clarity when it doesn't and take that extra effort. So as you know, next slide please, Melissa, the high-risk patients are often the ones that have multiple medical problems, which also lead to multiple medications. Now all of this is relative, so patients may have a lot of medical problems, but they're all under control and stable. But they might also have few medical problems that are uncontrolled and labile and relatively severe. We've all seen residents who've gone through multiple transitions, multiple nursing homes and hospital admissions, and that is a recipe for disaster for good care in many ways. And of course, all residents with cognitive or mental health issues are going to be at risk for issues, as well as those that are socially isolated or financially limited. And most of all, those that are non-English speaking, immigrants or refugees, add another layer of complexity for managing these residents and keeping them out of trouble. I borrowed a slide from Marguerite McLaughlin. Next slide, please. And this is from early on in the series, when she highlighted that the system is moving from a reimbursement based on volume to a reimbursement based on outcomes and value. How do we get to that? Well, I think the best strategy, which she illustrates here, are to go from an institutional care to an individualized care and from a fragmented system to a safe transition system. So I'm hoping that some of that will have been reinforced during the learning session, and we'll talk a bit about some of those issues with three components of high risk. Next slide, please. So the three components in this module are falls, high-risk medications, and hospital-acquired infections. Those will be presented in the learning module with learning sessions. But today we're going to highlight mostly on hospital-acquired or healthcare-associated infections. All of these are preventable. All of these are interlinked, as we see in the next slide. So, for example, next slide, please, Melissa. If you have a patient who's put on a high-risk medication, whether it's for incontinence or agitation, they often lead to a fall, which may then lead to a workup, which may lead to a diagnosis of a UTI, whether that's true or not. And the treatment with antibiotics might lead to C. diff, which often leads to dehydration, altered mental status, ED visit, and whether they're hospitalized or not, they might end up coming back with hospital-acquired infection, which might lead to another high-risk medication, and this cycle persists. And there are multiple areas within this cycle that we can intervene in many ways. So, and next slide, the falls section, which I will briefly highlight. Falls are a critical cause of preventable hospitalizations in nursing home residents. We know that. We see it on a daily basis in our institutions. The risks for it are multifactorial. They can be intrinsic and extrinsic to the resident. And the approach to that is to do a multifactorial intervention, so individualize the approach, which also includes systemic or cultural changes. This is a sine qua non of the definition of a geriatric syndrome. Next slide, please. CMS, the next category is high-risk medications. And these are based largely on Beer's list, which has been adopted by the HEDIS and, of course, CMS. The publication listed here is the latest one, but we are aware, and Dr. DeBow has been on this committee from American Geriatric Society, that a new updated list is coming out hopefully in a week or two. And hopefully those will also be adopted by HEDIS and CMS. There is, for your information, a pocket cards from AGF's app called iGeriatrics, if you're interested to have immediate access to any of this information. Of course, these medications are potentially inappropriate. They're high risk, and sometimes they're clinically appropriate, but we'd like to see if we can avoid them. And the main features of them is that they have a high risk of side effects. They're often ineffective in the primary aim for them. There are often safer alternatives available, and they're associated with poor outcomes unrelated to the medication, such as falls, dementia, or death even. So we'd like to avoid them. So the bulk of the rest of this presentation, next slide please, will be on HAIs. Next slide please. And the UMass group is going to present this for the rest of the time that we have left. And I wanted to highlight that the lessons for this module will be forthcoming. We are working on these right now. And I'm going to let the UMass folks introduce themselves. There's Drs. Gurwitz, DeBow, and Tharmalingam. And thank you very much.
Okay, thank you very much, Lynn, for that introduction and that nice presentation. My name is Jerry Gurwitz, and over the next 20 minutes or so, we will be talking about HAIs, and we'll be taking a case-based approach. And 3 cases will be presented, and there will be audience participation, so be ready for that. Next slide. I would like to reintroduce my colleagues, Dr. DeBow and Dr. Tharmalingam, who will be presenting the cases right now. So next slide.
Hi, this is Dr. DeBow. We're going to start with UTIs, and the first case is Mrs. Jones, who is an 83-year-old woman who's been living at your facility for a year. She frequently falls, has dementia, and diabetes. She returns to the facility after a 6-day hospitalization for pneumonia with a urinary catheter in place. Urology wants the catheter left in until they see her in 2 weeks. 2 days later, a family member reports that she, quote, doesn't seem quite herself. Her urine is cloudy with a strong odor. She has no dysuria or abdominal tenderness and is afebrile. The urinalysis shows leukocyte esterase is positive. There's 3+ bacteria and 40 to 60 white blood cells. The urine culture grows greater than 10 to the 6 of Klebsiella pneumonia, which is resistant to all oral antibiotics. Now, I'd like everyone to open your polling screen now, or that should be showing up. Is that up on the webinar? I'm not seeing it. Okay, there we go. So I've opened the polling. So how do you interpret these results? And please give your responses. She has asymptomatic bacteriuria and does not need antibiotics, or she should be treated for UTI because of confusion in a positive culture. A positive urinalysis and urine culture always means that a UTI is present, or she should receive antibiotics because the Klebsiella is highly resistant and you don't want it to spread to other residents. Okay, make sure you've filled out your poll. We'll give you about 10 more seconds. Okay. Next slide, can we see the results here? Okay. So it looks like, I'm trying to pull up the bar graph. We have a range of responses. And most of them are, she has asymptomatic bacteria and doesn't need antibiotics, which indeed is the correct answer. Now we'll go into some of the backgrounds for that answer. So the first one is, who should get a urinalysis? They should only be checked if the patient is symptomatic. Next. What are the symptoms of a UTI in residents with catheter that should prompt us to get a urinalysis? Well, it would be fevers, rigors, blood in the urine, suprapubic tenderness, costovertebral angle pain, or persistent unexplained symptoms such as a low blood pressure, an increased white blood cell count, or malaise. Next. Which signs and symptoms do not, in of themselves, mean the patient has a UTI? This is exactly what we saw in our patient. So cloudy urine, foul-smelling urine, and confusion do not, in of themselves, constitute a UTI unless one of these other symptoms are present. Next. So one of the questions is, if we do need a urinalysis, how do we best collect it from a patient with a catheter? Well, if it's a Foley catheter, optimum is to remove the catheter and obtain a midstream specimen. If that's not possible, then you remove the catheter, replace it with a new catheter, and obtain a sample from the new catheter. Or, and finally, if you're totally unable to do any of the above, would be to obtain a sample via the side port. Next. If the resident has a condom catheter, you should remove the catheter and obtain a midstream specimen. If that is not possible, you should remove the catheter, clean off the glands, apply a new catheter, and obtain a sample from the new collection bag. If that is not possible, then you should do straight catheterization. Next. So, we've done the urinalysis. How do we interpret the results? Positive findings on a urinalysis, such as pus, white cells, nitrite bacteria, do not in of themselves mean the patient has a UTI. And of course, if the urinalysis is negative, a UTI is unlikely. Next. So what is a UTI? You have to have bacteria in the urine plus UTI-specific symptoms, such as we saw on the earlier slide, like fever, suprapubic tenderness, and patients without catheters, things like frequency, new incontinence. These are the only patients or cases that should be treated with antibiotics, where there's bacteriuria plus the UTI-specific symptoms. Next. What's the harm of treating what is essentially asymptomatic bacteriuria? It can harm both the resident by causing multi-drug-resistant organisms or C. diff, and it's also a risk for caregivers and staff. There's a risk of colonization and possible even infection with drug-resistant microbes. Next. Next. So, what do we do with catheters in residents undergoing treatment for a UTI? Well, the first thing we need to go back and review, is this catheter really necessary? And of course, there are only 5 indications, and that is chronic urinary retention, stage 3 to 4 sacral or perineal wounds in incontinent residents, hospice or end-of-life care, the need for very accurate urine output monitoring when the patient can't participate, or in some postoperative cases when there's prolonged immobilization. Next. If there are none of these indications, then catheter should be removed. If a catheter is needed, consider intermittent catheterization, but if not possible, then would replace the catheter at the start of antimicrobial therapy. Next.
Okay, thank you, Dr. DeBose. So I will be doing the next 2 cases, which will be on C. diff and MRSA, respectively. So let's get started with the case. Mrs. Smith is admitted after hospitalization for a UTI and is placed in a double room. 3 days later, she develops diarrhea and is diagnosed with C. diff. The charge nurse sets up contact precautions and places a container of disinfectant wipes outside the room for cleaning the blood pressure machine after use on the patient with C. diff. She tells Mrs. Smith's roommate that she will need to use a commode so that she doesn't catch C. diff from the shared bathroom. The roommate complains to the administrator that she doesn't want to use a commode. The administrator calls you for advice. There are no single rooms available. Can we open the polling questions, please? So what is your recommended solution? Do you say that room changes are necessary and that all C. diff patients must be in single rooms? Or number 2, they can share the bathroom as long as they use disinfecting wipes to clean surfaces after they're done. Or maybe number 3, if you tell the roommate that she only needs to use the commode until Mrs. Smith has 3 negative C. diff tests. Or number 4, Mrs. Smith should use the commode and the roommate should use the bathroom. So there's 4 more seconds.
Please don't forget to hit submit at the bottom of the polling questions.
Okay, and let's look at the results, and we can move to the next slide as well. So the correct answer is number 4. Mrs. Smith should use the commode and the roommate should use the bathroom. I actually don't see the results tabulated. Okay, so the majority of you did not answer, but those that did answer correctly. So we'll explore this a bit further. Next slide. Next slide, please. Yeah. So what is C. diff? C. diff is a gram-positive anaerobic bacteria, and it produces 2 things. It produces a spore, which leads to its transmission and infection, and also a toxin that inflames the colon that leads to the symptoms and the pathologies that are associated with it. Next. So what are some of these complications of C. diff? Like I mentioned, it causes the inflammation of the colon, which can then lead to complications such as toxic megacolon, perforation of the colon, and a systemic inflammatory response or sepsis. Next. So then what are the symptoms of C. diff? Most commonly, it's watery diarrhea, again from the colonic inflammation, or it could be some non-specific symptoms such as fever, loss of appetite, nausea, or just abdominal pain and tenderness. Next. And so what are the risk factors in our residents for getting C. diff? As you can see by the list here, pretty much most of the residents meet one of the other risk factors. Next. So if you have a positive C. diff test, what is the difference between colonization and infection? Like I mentioned, both test positive, but a colonized patient does not have the symptoms that I mentioned previously, whereas an infected patient does. And how is this C. diff transmitted and acquired? It's transmitted via the spores, which can be on any surface, device, or material, and it's actually most commonly spread on the hands of healthcare personnel. And a scary fact is that unclean surfaces can have spores persisting on them for up to 5 months. Next. So what do we do to prevent this transmission? Number 1 is hand hygiene, but a very important fact here is that this hand hygiene should be with soap and water, not alcohol-based disinfectants. For killing the spores, you would need to use the soap and water. And this needs to be done prior to putting on gloves and gowns, and also should be done prior to entering the residence room. So you wash your hands, put on your gloves and gown, and then enter the residence room, and also repeat hygiene with soap and water after removing gloves and gowns. And another important element of adequate contact precautions is washing the resident's hand after use the commode, before eating, or any time when hands are soiled. Next. And like I mentioned, with the spores persisting for 5 months, how can you adequately disinfect your environmental surfaces? You have to use dedicated sporicidal agents. So regular standard disinfectants are not effective. You should use these sporicidal agents, and an alternate is bleach, which you can dilute. And this needs to be for all surfaces and for all equipment as well. Next. And then how do we cohort these patients who either are C. diff colonized or C. diff infected? Number 1, they should be in a private room. If that's unavailable, you can group together the residents who have C. diff, And if that's not possible, like in our patient, in the case, you use a commode for the resident with C. diff. Next. And these precautions, how long do you continue them? Well, if they're having diarrhea, you need to continue the precautions until at least the diarrhea stops. But spores can be transmitted in even well-formed stool for more than 48 hours after the diarrhea resolves. So a lot of institutions continue precautions for an additional 2+ days, or at least until the antibiotics are completed, or if you're an inpatient until discharge. Next. And a common question is, should we repeat C. diff testing to determine whether an infection is cleared? No, do not repeat testing. It can be persistently positive without clinical significance. Okay, thank you. Next. So case number 3, a lot of similarities, so let's get started. This is MRSA. So Mr. Collins returns after 10 days in the hospital for pneumonia with a new stage 3 large sacral decubitus that grew MRSA. He has diabetes, spinal stenosis, mild dementia, and CHF. The charge nurse feels that he should be in isolation in a private room. Mr. Collins' doctor, who's the medical director, said that isolation isn't necessary. So the charge nurse comes to you for backup. Let's open the polling question, please. So what is your recommendation? Do you say that Mr. Collins should be moved to a single room with universal precautions? Do you say, number 2, that he should be moved to a single room with contact precautions? Number 3, do you say he can stay in his room, just maintain respiratory precautions? Or number 4, he can stay in his room, but he should have contact precautions? Okay, so you have 10 more seconds.
And if you're doing the poll, it's at the bottom. Just make sure you submit your answer.
Okay, so the polls are closed. Let's move to the next the next slide. And we'll pull up the answers as well. So the correct answer is that he can stay in his room, but he should maintain contact precautions. And let's review the results. Okay, so the results aren't populating, but okay, there we go. So again, the majority did not answer, but of those who did answer correctly. So let's explore this a bit further. Next slide. Next slide. So what is MRSA? MRSA is a Staph aureus strain that's resistant to many antibiotics and is causing an increased amount or incidence of infections, up to 65%. Next. And again, MRSA is spread via direct contact with infected wounds or contaminated hands, usually by healthcare providers, so kind of similar to C. diff. But unlike C. diff, person-to-person transmission is more common than transfer from environmental surfaces. And it can also be spread via asymptomatic carriers who are colonized. Next. So should we actively screen all patients to detect colonization? I'm just going to say for time constraint that this is controversial. Some facilities are doing this, but the literature doesn't well support this practice. Next. So again, a positive MRSA culture, what does that mean? If they have no symptoms, then you can say they're MRSA colonized. And if they do have symptoms, then they have an active infection. Next. And so regardless of whether they're colonized or infected, what prevention strategies can we use to prevent transmission to other people? Number 1, hand hygiene. Number 2, contact precautions. Number 3, cohorting patients. And number 4, decontaminating environmental surfaces. And we'll explore this a bit more. Next slide. So if using contact precautions in someone who's MRSA colonized, how long do we continue this? There's no definite answer. If you don't do anything to decontaminate them, then you continue the precaution. Next slide. Do we need to wear masks only if they have respiratory symptoms, such as a lung infection? Next slide. And the best practice for hand hygiene, unlike C. diff, is either soap and water or alcohol-based hand gel. Next. And should we consider using just standard precautions only if they're colonized? Okay. And cohorting, similar to C. diff, private room, if that's not possible, cohort residents who have MRSA, not possible. You can group them with non-compromised residents. Next. And do we need to restrict movements? No, don't restrict their movements if they can practice good hand hygiene and if you can cover or contain their secretions. Next. And appropriate environmental cleaning, unlike C. diff, any regular disinfectants are appropriate, okay? And again, use dedicated equipment. And how do we prevent transmission? If they have a lung infection, it would be contact and airborne precautions. If they have a skin infection, just cover it so that their drainage doesn't make contact with the environment. And if they're not colonized, then just maintain the precautions like we talked about. Thank you.
So, in summary, this is Jerry Gurwitz again. How do we prevent HAIs? And based on these cases, in regard to hand hygiene, wash hands before and after care. Even if gloves are used, use soap and water for C. diff. Wash residents' hands too, that's very important. In regard to disinfection, environmental cleaning, disinfect all surfaces and personal equipment. Use bleach or other C. diff sporicidal solutions. And very key to everything we've presented today, antibiotic stewardship. Use antibiotics judiciously and only when absolutely necessary. Next slide. We all want to thank you for your attention today and let you know that there will be upcoming materials which relate to today's webinar, and the component will be entitled HAIs Beyond the Basics. So thank you again.
Great. Thank you, Drs. Gurwitz, DeVoe, Summerlin, and Dr. McNicoll for summarizing and giving us a snapshot of this learning module. Just so you know, these learning modules are meant as tools for you to use when you're training different staff members in your building, so we hope that you'll access them and use them in that manner. Next, I'm happy to turn the mic over to Margie McLaughlin, our Consultant Director of Education. Margie's been with us since the start of the collaborative as well, so I'm going to just introduce her and let her summarize the learning module entitled Getting a Seat at the Referral Table. Margie?
Thank you so much, Melissa. I'm delighted to be with all of you again. And this time I want to share with you something that I feel has become a really practical use of everyone's time. As you know, as we work throughout this whole process of reducing rehospitalizations, we've really had to concentrate on an enormous amount of both clinical and various topics, end of life. The whole module has been set up to really support ways to reduce rehospitalizations and to improve the lives of residents. Next slide. As you can see on this slide, and you've seen it before, I'm sure, is that this has become a costly problem all throughout our nation, and it is more importantly something that so definitely affects the lives of residents in a really negative way. As you know, CMS and throughout our country, many folks have worked to reduce rehospitalizations, and because of the nature of the cost of this, we're starting to see huge changes in the way that organizations are beginning to run. Many have begun to develop what they call accountable care organizations, which helps in combating some of the costliness of rehospitalizations and makes an effort to improve quality care by finding valuable partners who are doing quality work and bringing them together into a network. Next slide. You can see from this slide, this is data from quarter 3, 2014, what the national average looks like. Next slide. In order for this change to begin to take place, what we see is that homes will be asked to become very adept at their actual process of reducing rehospitalizations. Beginning next July, you'll see that there'll be a baseline measurement period for long-term care centers, and that data will be collected in October 2017. And as you look across the slide, what ultimately happens is that the federal government will be looking to ensure and expecting that homes across the country show remarkable change in the quality of transitions of care, hopefully reducing them considerably. Next slide. Next slide. Thank you. So what has happened is that CMS has implemented payment penalties, not only to hospitals with high 30-day readmission rates for discharges, particularly where it comes to CHF and pneumonia and myocardial infarction, but also hospitals have begun to participate in this ACO, or bundled payment demos, and it's helping in a lot of ways to reduce rehospitalization rates. Why hospitals care about you, you ask? Well, it's because they're counting on finding really high-quality partners who can help in this reduction. So admitting patients directly from the ER and clinics, referring to low readmission providers. And that's why we wanted to create a particular series or a particular module that helps you to be able to prove your value and quality to the hospitals. And so what we've done is we've seen this more and more around the country, is that people are working to create a referral resume. And when I say a referral resume, I mean very specifically a resume about your organization that shows others what your value is. Next slide. So what we look at is this becomes a very proactive response. So organizations around the country are actually building a little portfolio. And when I say a portfolio, I mean very, very specifically a show and tell portfolio of why you're great. This is like a little Kinko's project, if you will. It's a colored version with a little spiral, and it's meant to help to woo your potential partners. What it does is it demonstrates some of your data, and as our first speaker pointed out, there's lots of it. But to actually begin to create a little portfolio that shows some of the high points of who you are. It also discusses in your portfolio why this data matters to your residents and to the families around you. And it also helps you to validate that you're committed to continuous quality improvement. And so this becomes kind of a key part of this process of being part of a network, particularly in your community, maybe within your zip code area, but with the hospitals that are part of your community. Next slide. Some of the key components of this little resume, you want to be sure that you can demonstrate good clinical care outcomes, low readmission rates, of course, and excellent patient experience scores. And what I'm happy to tell you is that when you go to this module to actually build your resume, it actually gives you clear-cut steps. I'm going to give you a little teaser on some of the other things that you might want to include. Next slide. So when you're building it, what you want to do is to actually look at your aggregate profile of your residents. So if it turns out, for instance, in your home, 65% of your folks have dementia, what you might want to really begin to highlight is the great stuff you do to support people with dementia. What you want to do is also promote the quality measures. You want to be able to share your hospital readmission rates. And there's nothing better than being able to show your local hospital some of the satisfaction and family experience that's happened as it related to discharges from that hospital. So if 85 of your residents came from Merriam Hospital, for instance, what you want to be able to say to that hospital is 98% of the folks who came to our home from you were really pleased with our care. So you're really trying to individualize the actual exciting news of how pleased people were with the service. Next slide. This is just to give you an idea, this is just a really small one page. This is a home that had put together their referral resume and actually had one small cover sheet that showed people exactly who they were and what they had done. you'll please note that this particular home was also one of U.S. News and World Report's best nursing homes in the country in 2014. They were a Silver Quality Award winner, and they also had a 5-star. So they took some really great highlights. They made this a one-sheet piece of paper, and when they would go to meetings with hospital executives, along with their actual portfolio, they had this brief overview. In our module, you can take a look and begin to see how other people have done it. Next slide. What do you do if your data isn't great? Okay, so you're putting together your portfolio or your resume, and you haven't really got great stuff. Well, it turns out that if you can show trends that demonstrate how you're making efforts to improve, or how much improvement there's been, or even if you show that you recognize there was a problem and how right now your QAPI team is working on strategy, those things go a long way in exciting other people and helping them to see your efforts towards quality. What you also want to be showing is that you have a real passion for quality, and that you have a gang of folks who are also committed to it as well. And you want to be sure that you can ensure potential partners that you're on your way up. And so if your data isn't great, you can really build your story in a positive way. Next slide. One of the things that we've done over the last couple of months, as we've talked about rehospitalizations, be sure that you can identify your systems of care related to rehospitalizations. In some of the previous modules, we've talked about Interact, and we've talked about Eric Coleman's model. There's also a little piece on Hebrew Senior Life, and also this great guide that's called Send or Not to Send. Be sure to be able to identify to your partners what system you're using. Don't have one? Give some thought to some of these. Next slide. This is just, if you haven't read it already, this is from Jewish Hebrew Life, Hebrew Senior Life, and these folks did a great study. This article is within our modules, and it actually gives you great tips on how to actually reduce rehospitalizations and some of the great things they did. Next slide. 20% decline. Also, this is the guide that we spoke about, and you can also find that if you haven't already gone on. Excuse me. You'll see that you can use that as well. And next slide. For those who are using Interact, here's some who need to be persuaded to use Interact. What you'll see here is that those homes that embraced and engaged fully in the Interact program to reduce rehospitalizations were able to do it by 24%. So it might be worthwhile to really check into using the full Interact model. Next slide. Thanks so much.
Thank you, Margie, for this information about this learning module. I'm really looking forward to having it available by the end of this month. For everyone on the call, we're expecting that you can take these learning modules, like I said, and train your staff. They're available to you 24/7. And remember that it's you that are the people that are going to be the change agents in your building. And so we're here to provide you with some concrete tips and ideas and help you with some of the education. But how you deliver these things in your building and what you do with it is going to be specific to your facility. So thank you very much. At this time, we'll be able to address some questions. Morgan, can you please tell the participants how to ask a question?
So if you have a question, please press *6 on your phone to unmute your line and ask your question.
Also, we've been monitoring in the chat. There's been a few questions there, mostly technical, and we've addressed those. Now, are there any other questions in the chat? None so far. Okay.
Again, it is *6 to unmute your line.
Hello? Hi, do you have a question?
Yeah, we were just wondering what the Eric Coleman hospital reduction was about.
Eric Coleman is a doctor out of Colorado. He's received a number of different awards. He created a killer approach, and you can easily find that information if you just Google him. Based on his awards, he's become really quite popular. And I think Melissa can probably send out a link to Dr. Coleman's work.
Thank you. Absolutely. We can send out a link, and we can also have a link on our website. Thank you for that suggestion. Are there any other questions?
Hi, it's Lynn, McNicoll, and Melissa. I was really interested in the Duville dashboard as an example. So I wonder if they could share that, and if they'd be willing, we could put it on the website, because it seems like a great example of collating essential components of all the data and using that to build systems and issues that are across systems and aren't into silos. I really like their approach to it. I would have liked to have seen what it looks like. So if they're willing to share it, I'd love to see it, and I'm sure other nursing homes would love to see it too.
That's a great suggestion. Andrea, are you still on?
I am still on it. I'm happy to send that forward. That's no problem.
Okay, great. Thank you. Any other questions?
Hello. I have a question in regards to the MRSA isolation. So I'm not talking about respiratory at all. That's totally different. I'm talking probably a wound that can be covered, things like that, or in the possibly urine sepsis. So, like all nursing homes, you don't have everyone in a private. Maybe you do short-term or the specialty units, but in long-term, not everyone's in a private, so they're in a double. So if two residents are sharing a double, so we have extra precautions that one resident is on isolation precaution with MRSA. We make sure if it is urine that the bathroom is cleaned out after every use, a special disinfect. Any other recommendations?
So the secretions contain the MRSA, and not secretions, the drainage from the wound, and it seems like you guys are doing all of the appropriate interventions to minimize contact with that in the environment. So really, there's nothing further than good just putting the dressings on and good hand hygiene. I think that's pretty much.
I just wanted that confirmed by the experts. Thank you very much.
No problem.
Thank you for your question. Okay, do we have any other questions before we close today's session? Okay, so thank you all for joining us today, and please remember to contact your state QIO lead for more information how to share on one of our webinars or for more information on how to participate in the work. Everyone is at different points in the collaborative, and so we're here to help you. Just a few last announcements before we end today's webinar. And I'd like you to please take a few moments just to complete the webinar evaluation. Your feedback will help us improve the sessions and will provide you with more meaningful programs. Also, today's presentation is posted on our website, and a recording of this webinar will be available within a few days. Thank you so much for joining us today, and have a great day.